First of all, good evening to one and all, and thank you so much for this opportunity. However, I'm not a pediatric dietitian or a specialist. I'm a clinical nutritionist, but I'm trying to do. I'm surely trying to do justice to this topic today: nutritional management in childhood obesity. As all of us know, there are increasing number of kids who are turning overweight, and 80% of these kids would be reaching out to be obese during their adulthood as well, which would lead to a lot of medical problems related to whether it is cardiovascular system or respiratory system or the other systems. And what can we do to prevent it at a very preconceptional stage is what we should be looking at as clinical nutritionists. And so this is my presentation outline, what I'll be speaking about today. I'll be talking about childhood obesity and its prevalence, the cycle of childhood obesity, how it really happens and how it turns out to be an adult who turns out to be obese, potential health concerns, what are the consequences and contributors of childhood obesity, potential etiologies related to it, the treatment options, and also looking into a slight of surgical intervention. I'm sure actually we all would be liking to hear more from Sir later on these topics as well. And then followed by a case study who's a 15-year-old Indian female. So, and then the concluding remarks. Let's start with what is childhood obesity. So, basically, it's a condition where the body fat increases in a negative way, which affects the child's health and well being, whether it is physical or mental, having a lot of psychological pressure on the child. So, definitely affects the child in a negative way. It's a serious health problem, and it's not just a national concern, but it's a global concern and puts the children at a risk of long term health problems. The diagnosis of obesity is often done.
Priya, I don't know if I have the signatures of. Just message me tomorrow.
Uh,
I'll see if I have
can
her
you all please
signature.
mute yourself? I'll request everybody to mute yourself. Thank you. So, the diagnosis of obesity is often done based on the BMI, body mass index. All of us are aware of it and the formula for it as well. Globally, in 2010, understanding the prevalence of it, the number of overweight children under the age of 5 were estimated to be over 42 million, and close to 35 million of these were actually living in the developing countries, from developing countries. And the global prevalence of obesity has doubled from 1990 to 2015, if we look at it. In just 3 decades, the number of school going children and adolescents with obesity has increased by tenfold, and the International Association for the Study of Obesity, IASO, and IOTF, which is International Obesity Task Force, reckons that 200 million school children worldwide are either overweight or obese. That's a huge number. Childhood obesity is definitely epidemic in India, and we all have to look at it in a very serious way. National average, if we just see, with 14.4 million obese children in India, we are the second highest number of obese children. We have the second highest number of obese children in the world, which is next to China. And the prevalence of obesity among 5 to 19-year-old children, Indian children, ranges between 3.6 to 11.7%, and it's predicted that by 2025 there will be 17 million obese children in India, which is going to be having a tremendous ill effect on our adults, the future adults of our country. Over 60% of children who are overweight before puberty will be overweight in early adulthood, more likely to be obese as adults, and leading to increase in the various metabolic syndrome disorders, especially hypertension, type 2 DM, dyslipidemia, and non-alcoholic fatty liver disease. So we need to also understand what is the most important factor which is linked to obesity, especially in our country. It is urbanization, which is linked to that. Now, just to understand the BMI and how we calculate, I've just put a one chart, which is a pink one, which is related to the BMI chart index for girls. However, we do have for boys as well. And Sir was going to discuss about these things in detail, so he'll be coming up. But this is just of how it looks when we have to do for kids or children. This is the IAP chart, growth chart. BMI is acceptable for determining obesity for children 2 years and older. Center, in fact, now it is more like 5 years to 18 years. Earlier, it was 2 to 18 years. The Center for Disease Control and Prevention, CDC, has defined overweight as at or above the 95th percentile of BMI for age, and at risk for overweight when it is between 85th to 95th percentile. But as for the recent IAP 2015 charts, which we are supposed to be using the growth charts for them rather than using the CDC, which indicates overweight when it is more than 23rd adult equivalent of BMI, and obesity in children if it is more than 27th adult equivalent of BMI, which can be easily plotted on these graphs, which are very simple to use. If you can just plot the points as taking the age in years and the weight, the BMI calculated, you will get the BMI to be coming under whether it is 50th percentile, above 23rd, or above 27th, or so on. Now, understanding cycle of childhood obesity, how a healthy child actually turns out to be an obese adult. This is very interesting, but this is very very general, and all of us also know about it, what is going on, especially during the last 2 years of pandemic, that we have our children sitting at home and doing all online classes. This has been very usual. We see our kids and our friends' kids or family kids put on a lot of weight during this period because the physical activity has been compromised. So a healthy child generally, who gets into more of digitalization or technology comes in, or you are like using a lot of phone or social media, with the intake of high amounts or consumption of high fatty foods and little or restricted movement, turns to be mildly obese. That's your first step towards obesity. Of course, because of continued poor eating habits and lesser exercises, the child turns to be moderately obese. And when similar choices of food, whether the family or the parents or the children are following it at home on a routine basis, makes them put on a lot of weight, and exercises become little troublesome for them. They're not able to do it more often. They feel uncomfortable doing those exercises, and so it even reduces further, which leads to severe obesity. And this could be related to a high risk of asthma, diabetes, children having a lot of behavioral disorders. Now, this is a topic all by itself: behavioral disorders, depression, low self-esteem, having very low confidence on themselves because of the self physical image or appearance of themselves, obese, and this actually leads to an adult who turns out to be obese. Now, when it is so, you are more prone towards getting diseases like CAD, diabetes, pulmonary diseases, and leading to higher medical bills of healthcare facilities.
Thank you very much, first of all, for inviting me here and for that very kind introduction. It has been a great pleasure and an honor for me to be here on this platform, and would like to thank the organizers as well as Richa to allow me to say a few things about obesity and metabolic syndrome. I was actually listening to Richa, and I think she has already elucidated a few points about obesity. So let's start. If you could please have my next slide, please. So the specific objectives that I have put up together are to understand the pathogenesis of obesity, then to classify a child into overweight or obese depending on the BMI by plotting on specific growth charts. Then, how do we assess childhood obesity? How do we differentiate between simple nutritional obesity, endocrine obesity, monogenic obesity, and syndromic obesity? To understand what is metabolic syndrome in children and how to investigate it further, and then strategies for prevention and treatment of childhood obesity. So let's move on to the next slide, please. So I have put up a case here at the beginning. Here is a 12-year-old girl whose both parents are diabetic, and the only reason why they came to us is for the neck pigmentation. She was tall, her height was 152 and her weight was 60 kilos. And you can see the BMI was 25.9. Now, many of you who are used to looking at adult BMI might find that this BMI is all right. Why are we so worried about this BMI? But when we plot it on the growth chart, you can see how severe it is. So what I have put up here on the screen is the Indian Academy of Pediatrics Growth Chart application. You all can actually download this application and use in your routine clinical practice. It is called IAP Growth Chart and it is available on the Google Play Store. Now what you are seeing here is on the left side is the weight, and you can see she's on the 90th percentile. Her height is on the 75th percentile in the middle. But if you look at the BMI, that 25 BMI now is way above the red line, which is the obesity line or the 27th equivalent line for pediatric obesity. So this application not only tells you, plots it for you, but it also underneath interprets. It says BMI is above the obese percentile. So this was an obese child. Now, next thing that we did was to measure her waist circumference, and as you can see here, her waist is 93 centimeter. Now, some of you might know that we have designed the waist circumference percentiles for Indian boys and girls. And this plot that I am showing on this slide is the waist circumference for Indian children, and you can see here that she is way above the 97th percentile. Her blood pressure was 140/90, which is hypertension for this child. HbA1c is 7.8. So according to the American Diabetic Association, this is actually hypertension in pediatric population. And as you can see, she already had dyslipidemia. So next slide, please. So considering the fact that this is an obese child who also had dyslipidemia, hypertension, and she fulfills the criteria for metabolic syndrome, which I would elucidate further as we go along, we decided to give her nutritional advice and exercise. No medication or pharmacotherapy was given, and the whole family was involved into doing routine exercise and follow the diet, because that's the only way you are going to be successful. 6 months later, after she had followed the advice carefully, her height had grown by 2 centimeters and weight had dropped from 60 to 52 kilograms, and the BMI now was 21.9. Waist circumference had come down from 93 to 85. The fasting sugar had become normal. The PP sugar 134. Her cholesterol had come to acceptable limit, although still high. LDL on the borderline, HDL acceptable, triglycerides on the borderline. Next slide, please. Plotting the same child on the same application, you can see here that her height has gone up. Her weight has dropped from 98 to 75th percentile, and her BMI has come from obese to overweight percentile between the orange line and the red line. So the application has again interpreted it as overweight. Next slide, please. Now what next? Now typically this is a success story where the clinician as well as the nutritionist becomes very happy, and we have few words of praise which automatically come out of our mouth, and we say, oh well done, see, your lipids have improved, your sugars have improved, you are looking better. And typically that's the catch. The child feels that everything is over now, I am cured, and I am not going to do anything. So the next question is, do we say bye-bye? Do we follow up? How often? And typically with few praises from my side, she disappears. Doesn't come at all for follow-up. Next slide, please. Now she turns up at 14 years of age, and now the problem is she has come purely because there was no menarche. So she has primary amenorrhea. Now she has well-developed secondary sexual characters. She now has even worse acanthosis. The waist has gone to 100, weight has gone to 78, her BMI is 29.3. Again, she has become hypertensive and grossly dyslipidemic, this time with impaired fasting glucose. And she now has bilateral polycystic ovaries, as you can see here in this diagram. So now coming back to that BMI charting, as you can see here, is you now see that her weight has gone above 97 percentile and BMI is way above the danger line. So this child typically has gone back to the yo-yo phenomenon. Next slide, please. If you see the longitudinal graphs, the height has gone up, but the weight shows yo-yo, and worse is the BMI yo-yo. Any kid who is going to show this yo-yo phenomena is a bad news for long-term control, because this family has failed to understand the importance of long-term control. Next slide, please. So now what? We counseled her, we gave her nutritional advice, and here I started her on a pharmacotherapy, which was metformin, 500 milligram twice daily for 3 months. She loses 5 kgs in 3 months, starts her menses, lipids and sugar still remain abnormal. Now, what is the likely prognosis in a child like this? Sadly, in a kid who comes with a yo-yo phenomena, and despite metformin, when dyslipidemia persists, the prognosis is bad. So we should have really nipped it in the bud before she became obese, and I'll come to that when it comes to prevention of obesity. So next slide, please. So as you all know, obesity is a global epidemic. World Health Organization has declared it as the most neglected epidemic of modern times with significant health consequences. Next slide, please. But what is obesity? Obesity is excessive body fat or excessive adiposity. Now, the reliable methods for quantification of fat is either an MRI or DEXA or very sophisticated electric impedance techniques. But the best clinical way is to do BMI. It's a simple, reliable clinical tool for screening of obesity. Next slide, please. BMI is a surrogate marker of obesity. It's very easy to calculate by weight in kilos upon height in meters square. It's a reliable indicator for detection of overweight and obesity, but it cannot differentiate between body fat and muscle. So if you have a very muscular individual, the BMI will come high, and there you will need to have some way of measuring the body fat. Next slide, please. Now, BMI cutoffs for overweight obesity are age dependent and population dependent. So International Obesity Task Force says that 85th and 95th percentile for BMI as overweight and obesity cutoff. However, for Asian Indians, WHO has said that you need to lower the cutoffs to 23 adult equivalent and 27 adult equivalent for Indian population. Next slide, please. We therefore have designed the IAP, have designed the Indian BMI charts, and as you can see on your left hand side is the height weight chart, and on your right hand side is the BMI chart. The orange line is the 23 adult equivalent and the red line is the 27 adult equivalent respectively for overweight and obese, and on your x-axis is the age. So age has to be looked up on the x-axis, and corresponding figure on the y-axis should be plotted to get whether the child is overweight or obese. Next slide, please. Same thing for girls. Next slide. Now in 2020, I designed these charts for IAP, and they are called the user-friendly charts. Now some people cannot have the patience or the mathematical ability to calculate BMI on the go. So as you can see in these charts, on the left hand side, there is a BMI lookup tool given. Next slide, please. And this is the BMI lookup tool, very simple. On your x-axis, I have put up the height, and on your y-axis is the weight. And all that you have to join is height on x-axis and weight on y-axis. And depending on whether it falls below the black line, then you are underweight. Between black line and orange line, you are normal. Between orange and red, you are overweight, and above red line, you are obese. So I have made it very simple. You don't even need a calculation. But please bear in mind that these lookup tools are only applicable for children between the age of 8 to 18 years. For younger children, you still have to calculate and look up on the BMI chart. Next slide, please. Now let us come to younger children. The World Health Organization said that under the age of 5 years, you have to be a little more flexible when it comes to obesity. Next slide, please. These are girls' charts. Next slide. So the cutoffs are different. As I said, for 5 to 18-year-old Indian children, the BMI more than 23 adult equivalent, the orange line is overweight, more than 27, the red line is obesity. Next slide. But for younger children who are less than 5 years, little more allowance is made. That means if the child is above 1 standard deviation on WHO growth chart, now you are talking about weight for height. Here you don't use BMI, you use weight for height. So if it is more than +1 standard deviation for weight for height, but below +2 standard deviation, it's a risk for obesity. Above +2 standard deviation is overweight, and more than 3 standard deviation is obesity. So for little children, the WHO is allowing much more adiposity, much more chubbiness. Now, I am not yet entirely convinced whether for Asians it's the right policy, but until such a policy comes into action, we follow the WHO recommendation. Next slide, please. So I have put the same thing in slightly different format, and here I have said, what is the prevalence of obesity in India? Now you will be stunned to know that prevalence of obesity is anything between 2 to 8% in Indian cities, but the prevalence of overweight is now as high as 5 to 25%. So quarter of our population of young children is now overweight, and out of that 2 to 8% is obese. So I think we are following America. So we are looking at malnutrition at both ends in this country. Undernutrition as in malnutrition, and overnutrition as in malnutrition of the other type. So we as clinicians and as nutritionists and healthcare providers have to be very vigilant to pick up obesity at a younger age. Next slide, please. This was the prevalence of obesity in 2016 across India, and you can see the numbers are going up and up. There are many more obese children in north and south, but in east and west also now the obesity is increasing. Next slide, please. Now, what is the evolutionary physiology of obesity? Humans are predisposed to conserve body fat so that you can survive at times of famine and leanness. But the current scenario is that there is excess of calories, and therefore people are putting on too much fat. See, it is very unlikely that humans have existed on the face of earth for more than at least 100,000 years, maybe even a million years. And it is very unlikely that in less than 50 years a genetic change will occur. So all the obesity that we see today, or let us say 99% of obesity that we see today, is actually environmental. There are some confounding factors such as developmental disorders, genetic disorders, and other environmental issues. But please remember, the majority of obesity that you and I see today is lifestyle and excessive calories. Next slide, please. Now, eating behavior is very complex. You know, there are inhibitory and stimulatory brain influences. Then dropping sugars also stimulate appetite. And there are external factors, availability of food, type of food. Even people meet at party and they are so happy and jovial, they tend to eat more. Whereas if you go to a sad scenario, a sad situation, you don't feel like eating. So eating is a very complex behavior. So primarily when there are good times, people will eat more. Next slide, please. Now this just tells you about the physiology of feeding. As you tend to reduce your food intake, your leptin levels drop. It stimulates the agouti related protein and inhibits the POMC, the pro-melanocortin, that stimulates the cortex so that you feel hungry. Next slide, please. But as I mentioned earlier, while all this physiology and evolutionary physiology is important, daily cumulative imbalances of excessive calories over a period of time leads to excessive fat mass. So if every single day the child is having extra calories than what he or she spends, calories will be converted to fat every day, and over a period of time, just like your bank account, it just fattens and fattens. So it's the daily errors in cumulative energy balance that finally leads to obesity. Next slide, please. Next slide, please. I think I said this. Yeah, there's one thing I want to say is that there's something called as set point for body. Everybody's body has a set weight point. Now, as you can imagine, when children are actually growing up, if they remain slim, their set point is set at a lower level. So in adulthood, even if they put on some weight because of either excessive calorie intake or illness or inactivity, they tend to follow the same set point that was set in adolescence. Or in other words, what we are saying is that we need to keep our children and adolescents slim so that their set point is set at a lower level, and then it is much easier to lose weight later on in adulthood should they put on weight. But if your set point is set at a much higher level while you are developing as children and adults, all your life you will struggle to lose weight. Next slide, please. Now, this is again stating the same thing, that what do you observe in socio-economic status in India? Higher is the money, higher is the fat. Lower is the money, lower is the fat. We did a study in the city of Pune, and we actually had shown that in the year 2008 or 9, that obesity prevalence in PMC schools, Pune Municipal Corporation schools, is less than 0.1%. In Marathi medium school, it is 1%. And in English medium school, it is beyond 5%. That's the prevalence of obesity. So finally, as you can imagine, the same thing has been echoed by Dr. Marwa and Dr. Goyal across India. So it's all about money. Next slide, please. So there you go. This is Hemant Morparia's cartoon in Bombay Mirror in 2005. He says, pizzas, colas, burgers, candies. The kids pig out when we go shopping. And the gentleman says, they surely look malnourished to me. So this is the mall culture. That thin lady has been looking after her diet well, but look at her children. They are just hogging. So obesity, please remember, in 99% cases is a lifestyle disease. Next slide. Now, clinical presentations. Here I have put up some slides for you to recognize monogenic obesity. That is seen when it occurs in early childhood, and it is because of certain genes such as the leptin or POMC gene. Then comes the syndromic obesity, where you have mental retardation, dysmorphic feature, and organ-specific developmental abnormalities, particularly hearing and vision defect. Next one. Next one is that specific MC4R linked obesity, where there is variable severity of obesity and absence of specific phenotype. And generally, these children are tall, but they have excessive appetite. The minute they enter the clinic, they would keep on asking for food, So MC4R gene we do see in clinical practice. But remember, once again, more than 95 to 99% of your obesity is simple polygenic obesity, where it's all about nutrition and lifestyle. Next slide, please. So differential diagnosis, the rare forms, 1 to 5%, are endocrine obesity, which is caused by hormones, where a child is usually short and obese. Whereas for all other disorders, you have tall and overweight children. Then there can be genetic obesity, which usually starts before the 5th birthday, generally within the first 2 years. And then there is hyperphagia, which is hypothalamic. There is usually family history, and they are often associated with vision and hearing defects. So if you see an obese child who has vision and hearing defect, very early obesity, and extreme hyperphagia, do think of genetic defects. Next slide, please. Now, the common hormones that cause obesity are growth hormone deficiency, hypothyroidism, excess of cortisol causing Cushing syndrome, and hypothalamic obesity. But as I said, height and weight velocity are reduced in endocrine obesity, whereas in nutritional obesity, they are tall and overweight. Next slide, please. Now let us talk about metabolic syndrome in brief. Metabolic syndrome is caused by a constellation of biochemical and clinical abnormalities. So the first criterion is to have a large central obesity, waist circumference above 90th percentile, For the age, gender and ethnicity, and as I told you earlier, we have designed the Indian charts of waist circumference, so you can use them, plus 2 or more of the following. And what are they? Triglycerides more than 150, HDL less than 40, blood pressure. Now the values which I have put up are for adults, but please remember they are age specific values of hypertension, and fasting glucose more than 100. If any of these two criteria are present along with a waist circumference which is bigger, then you call it metabolic syndrome. Next slide please. For children, it cannot be diagnosed under the age of 10 years or before puberty has occurred. And the criteria are age specific, but primarily they are the same as I mentioned in the earlier slide. Next slide please. For children who are older than 16 years, you use the same adult criteria. And I have shown the differences in red, that your waist circumference about 90th percentile, 90 centimeters for boys and 80 centimeters for girls, plus 2 of the following, very similar to the earlier slides, but the triglyceride more than 150, HDL less than 40, blood pressure more than 130 over 85, and glucose more than 100. Next slide please. I spoke about the waist circumference, and in that paper we make a point that don't wait until the waist circumference has gone beyond 90th percentile. You can probably start worrying when it goes beyond 70th percentile itself. Next slide please. So this is where you measure the waist between the midpoint of the iliac crest and the lower costal margin, the lower rib. Next slide please. Now these are the charts that I have been talking about, that you have got on your left hand side is the boys waist circumference and on your right is the girls, and we have highlighted the 70th percentile, beyond which only we should start counseling the family, not wait until it goes beyond 90. Next slide please. So these are the risk factors for metabolic syndrome, and they include, it's an interplay between environment and genetics. There is childhood obesity, then there are increased leptin levels, there is insulin resistance that further leads to the problem of hyperglycemia, hypertension and dyslipidemia. So what is an adaptive mechanism that becomes a disadaptation leading to metabolic syndrome? This is the evolution of metabolic syndrome over a period of time in a child's life. Next slide please. Now, how do you approach a child who is obese? You take a good history, and in history you ask for excessive thirst, excessive urination, headaches which point towards hypertension, snoring. Now sleep apnea syndrome is quite common in obese children, and if it is there, it needs to be treated. Then gastrointestinal discomfort, any musculoskeletal disorders, hyperphagia, visual complaints, hearing defects, acne, hirsutism, menstrual irregularities, and any underlying psychiatric disorder. Next slide please. Then in birth history, remember, children who are born either very small or children who are born very large. So the extreme ends of birth weight are more prone for obesity and metabolic syndrome in later life. Then ask for developmental history if there is developmental delay. Now, age of onset of obesity is very critical. If the obesity starts at a very young age, it's likely to be syndromic or genetic. And as I said, if a child is short and fat, then it's a hormonal disorder, whereas a tall and fat child is nutritional. Then take family history. Family history for just a minute. Family history for obesity, type 2 diabetes, then any liver disorder, and in case of women, polycystic ovaries and infertility. Next slide, please. Now, assessment of diet and physical activity. Now, you all are experts, much better than I am, when it comes to assessing nutrition. And I am very grateful to the entire community of nutritionists who help me throughout my practice in trying to explain and control children with obesity. So keep up the good work. But just a few points I thought I would enlist is assess the dietary intake, assess calorie, protein, fat separately, ask the patient to keep food diary, and remember that many children and adults who are overweight actually lie. They do not write what they actually eat. So keep that in mind. Then consumption of energy dense and fatty food. Then frequency of type of snacks, sedentary behavior are spent in front of the screen. Now in the time of lockdown, I often see children who actually are glued to the screen for more than 9 to 10 hours in a day. That is ridiculous, but that's happening. And physical activity and its type. I think this is the most important step in evaluation of detailed assessment of a child and family who have obesity. Next slide, please. Then in medication history, ask for any steroid intake, any anti-epileptics which can make the child gain weight, antipsychotics and antidepressant. All these medications are known to cause excessive weight gain in an adolescent. Generally, these are not used in very young children except the anti-epileptics. Next slide, please. Can I have the next slide, please? Then in clinical examination, take the weight, height, plot on the growth chart. The application is very useful. I urge you to download the IAP application. It actually takes the pain out of plotting. Then to the BMI, waist circumference, blood pressure. Excuse me. Look for acanthosis nigricans, acne hirsutism. In case of children with ophthalmic problem, doctors should do the fundoscopic examination. Then look at the joint problems. Look at if there is peripheral edema, if there is a thyroid swelling, goiter, and do a neurodevelopmental assessment. Next slide, please. Now, comorbidities. A lot of obese children have many morbidities. Particularly, they may have diabetes or impaired glucose tolerance, and an oral glucose tolerance test may be required. Dyslipidemia, liver function test. Non-alcoholic fatty disease of the liver is pretty common in children who are very obese, and I find that about 10 to 50% of all my patients show non-alcoholic fatty liver. Then in case of polycystic ovary syndrome, look for other investigation pertaining to that particular disease. And for obstructive sleep apnea, please do a sleep study.
Yeah.
Please do a sleep study. Next slide, please.
Okay.
So you screen for comorbidities by doing HbA1c, fasting glucose, then
She
oral
already
glucose
started.
tolerance.
We'll see.
Sorry, oral glucose tolerance test, and do a random plasma glucose, and if it is more than 200, it's diabetes. Next slide, please. Now this is the clinical approach. So you take the history and physical examination, see if it is abnormal or if it is normal, or normal with some comorbidities. If it is normal with comorbidities, then do dietary and lifestyle modification, address the comorbidities. If it is abnormal, then if the child is short and fat, you are looking at hormonal disorder. If you have hearing vision defect, very early obesity, genetic disorder. And if you have CNS abnormalities, you are looking at hypothalamic obesity. Next slide, please. Now, obesity prevention. Now, as you all know, there is a very famous saying that obesity does not run in families, but they are obese because nobody runs in the family. So that is the thing, that managing obesity is a family affair. And then you have micro environment and macro environment. Micro environment is the family environment, where you approach the family and teach them right from the beginning the importance of good nutrition, regular physical activity, and reduced screen time. At school level, now we have schools where there are no playgrounds. So we ought to have schools which have enough facility for children to play. There should not be fast food selling restaurant or outlet within at least 1,000 meters of the school. And at community level, I think that's where the political will is very important. That there should not be advertisement on the television where fat children are shown as normal. There should not be constant food advertisement of fatty food. That's the macro environment. So for prevention, we need a national approach, a local approach, and a family approach. Next slide, please. So lifestyle modification do's and don'ts I have put in. So sweetened beverages, fast food, high fructose containing corn syrups, high calorie snacks are to be avoided. Vegetables, sprouts, salad, fruits, high fiber diet is to be encouraged. Physical activity, WHO says that you must have at least 150 minutes of vigorous physical activity to prevent obesity, and much more than that to treat obesity. So always encourage healthy sleeping pattern. See that early to bed, early to rise makes you healthy, wealthy and wise is very true. Today children sleep at 1 and 2 a.m. and wake up at 9 and 10 a.m. That's a very unhealthy sleeping pattern that will make you obese. Next slide, please. So recommendation for obesity treatment, primarily it's an intensive, age appropriate, culturally sensitive, family oriented lifestyle change. Then comes the portion control education, reduce saturated dietary fat and adequate intake of fiber, adequate intake of dietary fiber, fruits and vegetables, timely regular meals and avoid in between meal snacking, and then organized eating. And then when a child gives a clue or a cue that he doesn't need to be fed, we should teach the mother to respect that. I mean, I find in my clinical practice 99% of women are trying to feed their children all the time for first 2 years of life. That actually damages their natural ways of appetite and satiety control. It's a sad thing that in India, a mother's, I would say, success depends on how chubby the child is. It's such a foolish family behavior that is exhibited by our people, that in the first year, let the child decide. After breastfeeding is complete, let the baby decide what he or she wants to eat. Offering is the job of the parent, not feeding. We must insist this in young children at every single visit. Next slide, please. Now the treatment of obesity, these are some of my last slides, in which we must identify the maladaptive rearing practices. We must educate the families in food habits and correct amount of physical activity. We must diagnose unhealthy intra-family communication problems. We must support them by rearing patterns that seek to enhance self-esteem in a child and adolescent who is already obese. We must evaluate the psychosocial abnormalities, and then we must prescribe, counsel, and if necessary, only medications. Next slide, please. Now, pharmacotherapy, just a few words. There are almost no medications which are licensed to use in pediatric practice except probably 3. And they are metformin, where there is type 2 diabetes in adolescents or excessive insulin resistance in adolescents. Then orlistat, which is a medicine that stops absorption of fatty food, but it is very difficult to cope with because leaking and flatulence is such a problem that children can often not actually attend school. And the third medication, which has recently been approved by FDA, is an injectable medicine called liraglutide. Liraglutide is a GLP inhibitor, and that has shown about 1 to 3% weight loss if used as a subcutaneous injection for a few weeks. I am personally very skeptical still about liraglutide, but I do use metformin sometimes. I do not use orlistat because my patients can't cope with it. Next slide, please. So I have said all this, so we'll move on to the next slide. Last couple of slides on bariatric surgery. It's only meant for adolescents who have a BMI beyond 40 plus some associated comorbidities. It can only be done when the child has stopped growing. You cannot do it in a growing child. Extreme obesity and complete failure of lifestyle modification and pharmacotherapy is the only reason to ask somebody to have a bariatric surgery. But psychological evaluation must confirm that the family is stable and is competent with coping with post-bariatric surgery management. And the patient should demonstrate the ability to adhere to the principles of healthy dietary and eating habits after the surgery is done. You need to have an experienced bariatric surgeon and a good team to support the patient after the bariatric surgery. So it's not something that I would recommend before 16 years for sure, and rarely before 18 years. Next slide, please. Now, I have said a few things about prevention, so I may skip this slide. Next one. So my take-home messages are: nutritional obesity is the commonest entity prevalent amongst overweight and obese children. Think of endocrine obesity only in a child who is short and obese. Think of syndromic obesity if a child shows developmental delay, hypogonadism, a hearing defect and vision defect. Next slide, please. Prevention is always better than cure, and we must inculcate healthy eating abilities and healthy lifestyle in all our patients and families. Early screening and preventive measures at school and community level are very essential to stop this pandemic of obesity. Strict dietary modification, portion size control, intensive physical activity, and active involvement of the whole family is the key to success of obesity management. Pharmacotherapy and bariatric surgery have a very limited role in childhood and adolescent obesity management. Thank you.